Hello students, good evening and a very warm welcome to ENT Thursdays. Can you hear me? Am I audible? Can you hear me? So I hope you are taking good care of yourself during these difficult times and taking care of your family, maintaining distancing and keeping good hygienic measures. And in this difficult time, it is so much of realization. It is such an important time to realize that we have got such a beautiful life, and each and every day that we have cannot be rewinded, it cannot be relived. The only thing that can be relived are the memories. So make each and every day memorable. We are blessed to have this life, so make it memorable, make it a blessing for yourself, make it a blessing for others. And you are in such a profession that even if you are earning, even if you're charging, what you're doing is a social service, and you are definitely a blessing to everybody around you. So we will start with the ENT Thursdays, and yes, this time, like what the exams nowadays are expecting from us is that they want you to start thinking with an open mind as clinicians. They want you to think as clinicians. They want you to answer as clinicians, and the questions that they're giving are totally clinical questions. And but what happens is, what I'm noticing is that when we read the questions in the form of MCQs, the moment we read the questions, before we finish reading the question, immediately our attention goes to the four choices of the MCQs, and then our thinking starts getting limited. That is not what we are expected to do. So let us bring one change here. What we have to do is, in any subject that we are reading, the moment we read any question, let us just think about the question before seeing any MCQs, before seeing any choices. So that it should be a normal pattern when you're preparing, so that you keep your mind open. And when you keep your mind open, your mind opens to so many possibilities, and then no matter how many choices they put in the form of those four choices, you will be able to answer them correctly. So, what do you think? Wouldn't that be a great idea? I thought of experimenting that, and that is why in this ENT Thursday, what I have thought of, what I have done is, I have just removed all the choices so that you can think openly with an open mind. So let us see how that works, and I think that is definitely going to work. That is definitely going to be of help, of benefit. So we start with the first question, and the first question is, now the purpose of ENT Thursdays is to stimulate you to think. It is not spoon feeding in any way. It is to stimulate you to think. It is to keep you motivated, so that you have some small topic, you read it, and then you see what how much you retain, what are the improvements that you can make. So this is just one small part of the 19 subjects that we are doing. So if there is something that you feel that some improvements that can be made in your studying in this subject, you can do it in other subjects also. If you need revision, if you need to go in further depth, or whatever you can apply here, you can do it in other subjects also. So that is why we are doing it, and we are maintaining a continuity. So this is nowhere to spoon feed you. So you have to study. We are giving a small topic, you have to prepare everything, and then there's a challenge that how much uh, you can reproduce. So the first question we have here is, okay, so the first question we have here is, 65-year-old male, chronic smoker, presented with hoarseness for 1 month. There is no other complaints. Neck examination did not reveal any abnormal finding. Laryngoscopy shows the following. So the picture is given here. Biopsy was taken under GA, which showed squamous cell carcinoma. So we already have the diagnosis in our hand that this mass that we are seeing is a squamous cell carcinoma. What should the management be? So we are not having any choices in front of us. So now your mind is open and you can think about what are the choices that you have for the management. Yes, yes. So the first thing that should come to your mind is how are you going to stage this? Yes. So once you are going to stage this, accordingly you are going to manage this patient. So the first thing that comes to your mind is what is this lesion? Where are you seeing this? This is a squamous cell carcinoma. This is a squamous cell carcinoma of which area? Supraglottis, glottis, or subglottis? Yes, this is confined to which area? Yes, we can see this is confined to. Yes, very good. To the yes, I'm waiting for your answer. This is the glottis, that is where we are seeing the lesion, and this is limited to one vocal cord. So can you exactly tell me the T staging? T staging. T will be, yes, T will be when it is limited to one vocal cord, it becomes a T. Yes, one subsite is T1. Okay, so this is T1, and this is limited to one vocal cord, so this is T1. Yes, T1A. This is T1A. Okay. Now, what should be the management of T1A? I can see you answering. I can see that, yes, all of you answering is perfectly correct. It is T1A. I can see that the answer of T1A, somebody is telling it is microlaryngeal surgery with radiotherapy, and some of you are telling that we should go for radiotherapy, some of you are telling that we should go for radiation and TLM, some of you say it is TLM. So we have so many options here. It can be, you say it has to be TLM, it can be a radiotherapy, it can be TLM plus radiotherapy. Okay. Okay, so what do you think it should be? TLM radiotherapy, and no lymph node, no N0 node, so T1A, N0, M0, exactly, you have given me the correct. Now yes, glottic mid-cord lesion, radiotherapy with TLM. So there is another radiotherapy with TLM. So what is the management of this patient? Do we give radiotherapy also? Do we excise it also? So do we go for laser management with carbon dioxide is another answer that I am getting. Along with radiotherapy, TLM is another answer that I am getting. Laser treatment with carbon dioxide. Okay, now see, I know that carcinoma larynx is one place that you find it a little confusing. What is TLM? What is radiotherapy? Whether both should be combined together. Now, listen carefully. When it is an initial stage tumor, stage 1, stage 2, T1 or T2, we always go for a single modality treatment. That can be an excision or it can be a radiotherapy. Now, excision, how do we excise it? If we have to excise this lesion that we are seeing, now we can excise it by endoscopically. I can see Ratandeep answering as management, laser management by carbon dioxide. Now, this excision by laser is what is known as transoral laser microsurgery. It is known as transoral laser microsurgery because we are doing it transorally with the help of instruments. We are not opening the larynx anywhere from outside. We are not giving any external incision. We are going through direct laryngoscopic and through instruments we are, and along with laser we are excising it. This is what is known as transoral laser microsurgery. So in transoral laser microsurgery, you are going to excise it, and how you can excise it, depending upon the size of the tumor, you can go for subligamental, you can go for subepithelial, subligamental, or transmuscular, or you can go for total excision of the vocal cord, depending upon the size of the lesion. That is what is transoral oral laser microsurgery. Now, for early stages T1A, in this patient we can go either for early stages we can go either for TLM or for radiotherapy. Now, what is the disadvantages of radiotherapy over TLM? Now, when we have to give radiotherapy has to be given for at least 3 to 4 weeks. 3 to 4 weeks therapy has to be given. It has to be external radiation, which means that only the larynx will not be affected. There will be external, the tissues outside around the larynx also will be affected by radiation. Whereas in TLM, now we have seen how a vocal polyp looks like. We have seen how granulomas look like. There also we remove the polyp, we remove the granuloma. Yes, not causing much effect on the voice. So this lesion is appearing very much like this. It is appearing like a small lesion of the mid cord, which we can very easily excise. And this, if we excise it, this will be a single day procedure, just under GA, maybe an hour or two procedure. That's it. And after that the patient is fine, it will heal, and since it is not a very big lesion, there will not be much defect in voice also. So in this patient in T1, if the patient in this patient in stage 1 or 2, in T1 and T2, we can go either for TLM or we can go for radiotherapy. Now this specific lesion T1A, where it is a mid-cord lesion, we are not going to give the option of radiotherapy to the patient, because this we can very easily excise. We can see all the margins. The margins are very clearly visible. We can completely excise the tumor. Is that very clear? Is that very clear to all of you? Yes. So yes, we can excise it. Yes, post surgery we will give just the broad spectrum antibiotics. Jay is asking me which antibiotics. So that is just the broad spectrum antibiotics that we give for any surgery will be given here. Okay. Now, so we have come down to the diagnosis, and we have made the management. We will give this patient transoral laser microsurgery. Okay, now what are you going to do for the neck of the patient? How are you going to manage the neck of the patient? Okay, before that, somebody asked that, somebody told me that whether, yes, some of you answered that there will be TLM plus radiotherapy. Will you give TLM also and radiotherapy also? No. In early stages, it is a single modality treatment, either only TLM or only radiotherapy. The benefit of TLM, I have told you, it is a single day procedure. The second benefit of TLM is that once you have done once you have done excision, by chance the patient develops a recurrence, we have the option of radiotherapy for the patient. If we give radiotherapy to any patient once, radiotherapy to the same site cannot be given again. So if we have given radiotherapy to this patient for this small lesion, then radiotherapy cannot be given if he develops recurrence. So that is why if it is a small lesion, we can completely excise it, we will go for TLM. So if this is the picture given, we know that yes, this is T1A and we are going to give TLM for this patient. Okay, so how are you going to manage the neck of the patient? Tell me, how are you going to manage the neck of this patient? Which of the following lymph node in the neck should be removed in this patient? In this patient, how will you manage the neck? So coming back to the question, the neck examination of this patient did not reveal any abnormal finding. So yes, Divya says that in T1 and T2 we can do radiotherapy and TLM. That is what I have told you in class. Exactly, that is what I have told you in class. But please see again, I specifically mentioned that T1A mid-cord lesion. In T1A mid-cord lesion, where complete margins can be seen, we can excise the tumor completely. That is the only place where we do not give the option of radiotherapy to the patient. Okay, no lymph node, so no neck dissection, because glottic has no lymph node. Okay, so yes, very good. So because glottis does not have any lymph node, we are not, the lymphatic metastasis is not there in glottis. In this patient, we are not going to go for any neck dissection. So in this patient, we are not going to remove any neck nodes, because this is a glottic carcinoma. This is a glottic carcinoma, and there are no neck nodes. So in this patient, whatever the choice was, if in the choice we could have had TLM, we could have had radiotherapy, radiotherapy, we could have had radiotherapy plus TLM, we could have had total laryngectomy, or we could have had TLM plus neck dissection. Whatever the choice would be, once you read the question, that if the choices, just don't focus on the choices, don't see the choices at all while you're preparing. So that keeps your mind open. Now let us quickly come to the next question. So here we have the next question. A 65-year-old male chronic smoker presented with hoarseness for 4 months. So here the patient has hoarseness for 4 months. He is a chronic smoker, no other complaints. Neck examination did not show any abnormal finding. On laryngoscopy, both the vocal cords were mobile. So both the vocal cords were mobile and falling appearance was seen. So here on laryngoscopy, we are seeing this vocal cord appearance. Biopsy was taken under GA, which showed squamous cell carcinoma. Okay, so here also the diagnosis is given. CT shows involvement of only the vocal cord. So CT also shows that what picture we are seeing on laryngoscopy is exactly what the involvement is. There is no involvement of anything else. So what should his management be? So yes, tell me. To see the management, we are first again going to stage this patient. So how are you going to stage this patient? What is the stage of this patient? So the first thing is, yes, we are going to see whether this is a supraglottic, a glottic, or subglottic. Yes, yes. Suraj, you write radiotherapy plus TLM. So do you mean that it is radiotherapy along with TLM, or you mean by that that it is either radiotherapy or TLM? Yes, very good. It is a T1 or T2. What do you think it is, T1 or T2? T1 or T2? Mohammed, Swati, it is T1 or T2? Uh, Venkatesh, no. Venkatesh, this is T1A. Is it T1A? T1B? This is T1 or T2. This is glottic carcinoma. Excellent. This is glottic carcinoma. Now, what is glottic? Yes, this is a glottic carcinoma that we know. Now, what is T1? T1 means it is limited only to one subsite. So, we know that larynx has three subsites: supraglottis, glottis, and subglottis. So, this is limited only to the glottis, that is one subsite. So, that is T1. T2 is when it goes to the other subsite also. So, yes, this is T1 because it is limited only to the glottis, only to the true vocal cords. Now this is T1A or T1B. It is involving T1A is only one vocal cord, T1B is when it is going to both the vocal cords. So this is T1B. So whether it is a stage 1, T1 or T2, the management can be. Yes, so now I'm waiting for your management. So yes, you young doctors, how are you going to manage this patient? What are you going to advise to this patient? What will you advise to this patient? Patient will tell you, doctor साहब, what should I get done? Should I get operated? या सिकाई करा ले, या ऑपरेशन की जरूरत है, क्या करेंगे? ऑपरेशन कराएं या सिकाई करा लें? Yes, radiotherapy is what they call as सिकाई. Yes, क्या बताओगे आप? क्या कराओगे इनका? आप रेडियोथेरेपी कराओगे या आप इनकी ऑपरेशन कराओगे? ऑपरेशन कराओगे तो क्या कराओगे? ऑपरेशन में आप बाहर से चीरा लगा के ऑपरेशन कराओगे या अंदर से दूरबीन से आप निकालोगे इसको? यू विल गो फॉर TLM और यू विल गो फॉर ओपन सर्जरी? Yes, radiotherapy or TLM. Now, yes, very good. This is a stage 1 or stage 2. So, very nice. We can either go for either a TLM or, so it is not TLM plus radiotherapy. It is either TLM or radiotherapy. Now, either thing in the choice would be correct. Both will usually not be given in the choice. TLM or radiotherapy, both will not be given in the choice. Both can be correct, but now in this scenario, you are the doctor, you have the patient in front of you, you have the lesion in front of you, you are going to choose and tell me, in this patient, if you have to choose in between TLM and radiotherapy, what will you choose? All of you, tell me, what will you choose? Will you go for excision of the tumor, or will you go for a radiotherapy? What will you go for? TLM or radiotherapy? Both, if given uh, either TLM or radiotherapy is given, one is given in the choice, you can mark either. But if both are given in the choice, what would be if this is the picture that is given? This is the picture. Yes, very good, Jay. You say it is radiotherapy. Divya, Soham, TLM, Suraj says it is radiotherapy, Harshita. Okay, now just think that you are, if all of you who think that you are going to excise this tumor, you will have to excise this tumor from here also. The entire commissioner is also involved here. Okay, so this much also you will have to excise. You will have to excise this big tumor from here also. That is what is appearing, okay, to be involved. So if you remove so much of the tumor from both the sides, so will there be the voice, the restoration following surgery, the voice, do you think will be so easy? No. So in this case, the better answer will be to go for a radiotherapy. If we go for radiotherapy, we are preserving both the vocal cords. If it had been just one lesion here or one lesion which is localized here, we are removing only one part of the vocal cord, then it would have been better that we go for TLM. But here in this case, both the vocal cords and tear commissure, so much of the vocal cord is involved. If we remove all of this, then following surgery difficulty in voice will be there. So it is always better that in this case we go for radiotherapy. So now do you understand why we say that either for T1 or for T2, the management can be either TLM or it can be radiotherapy. Both are equivalent in results. The choice depends upon the extent of the lesion, where all it is going. Otherwise, both can be the answer if one is given in the choice, or if the extent is not given, either can be the answer. So I hope that makes things clearer to you. Have you got it? Have you understood that now? Okay, so now how are you going to manage the neck of this patient? Again, if in the choice is given TLM with radiotherapy, TLM with neck dissection, will you go for a neck dissection for this patient? Will you go for a neck dissection for this patient? Give me two reasons why you will not go for a neck dissection for this patient. Two reasons why you are not going to go for neck dissection. Neck dissection for this patient. Okay. Yes, very good. First, because it is a glottic carcinoma where the lymphatic metastasis is very poor, so no need for neck dissection. And second, in this patient, there is neck examination does not reveal any abnormal finding. There is no abnormal finding. Yes, so here just by seeing the lesion, in the lesion also, when we are seeing the lesion here, it is also given that vocal cords are mobile. That also tells us that this is a less than T3 lesion. No? Yes. No lymph node involvement. Yes, it is limited to the glottis and there is no lymph node involvement. Excellent. That was great. So now we come to the next question. So we have the next question here. A 65-year-old male, and he is a chronic smoker, presented with a complaint of foreign body sensation of the throat, dysphagia, pain in the left ear for 1 month. There are no other complaints, and neck examination did not reveal any abnormal finding. Laryngoscopy shows the following. Biopsy was taken under GA. Okay, and it shows squamous cell carcinoma. What things should be looked for making concurrent chemoradiation as the treatment modality for this patient? So here we have a chronic smoker who has a squamous cell carcinoma. Squamous cell carcinoma, which is the area of the squamous cell carcinoma? Squamous cell carcinoma, which area is this? Which area of the larynx is this involving? Is it a supraglottic? Is it a glottic or a subglottic carcinoma? Yes, so the first thing when we are seeing the lesion is immediately we are seeing whether it is supraglottic, glottic or subglottic. Okay, now many a times I hope now that we have done so much of larynx, I hope that you have you can very easily identify now in this picture also. Now if I ask you to identify that which is the anterior part of the vocal cord and which is the posterior part of the vocal cord, can you make out whether which is anterior and which is posterior? Yes, how do we identify that? Where the two vocal cords meet. where we have the V, that is the anterior commissure. So that is anterior and that is posterior. Okay, because many a times we have a picture like this given, and sometimes the picture that is given is like this. Sometimes the picture that is given is like this. So in this, what is anterior and what is posterior? Yes, can you make out which is anterior and posterior? So again we see this. Yes, that is how you identify. This is the anterior commissure where the two vocal cords are meeting, the V, the tip of the V. This is the anterior and this is the posterior. Yes. Okay, so now we come to this. Okay, so here what we are seeing is that the vocal cords we are not seeing completely. It is going like this. So there will be the tip, that is the anterior part. This is the posterior part. So this is the aryepiglottic fold part, the arytenoid part, and this is, yes, of the supraglottis. Okay, so what Venkatesh is writing is fixed vocal cord involvement of. Okay, very good, excellent. Yes, yes, yes. So what? When will you go for concurrent chemoradiation as a treatment modality? So concurrent chemoradiation is given in which stage? Concurrent chemoradiation. For giving concurrent chemoradiation, the stage has to be stage. Which stage? Concurrent chemoradiation means it has to be stage 1, stage 2, stage 3 or stage 4. Concurrent chemoradiation. Concurrent chemoradiation means, very good, it has to be T3. Excellent. Very good. It has to be T3. So in T4 also is the management concurrent chemoradiation. In T4 is the management concurrent chemoradiation or is it a total laryngectomy? In T4. Yes, in T4 the management is Ayush. In T4 also do we give concurrent chemoradiation in very selected cases where the very limited T4, but usually for most of the cases for T4, what is the management? For T4 the management is, yes Suraj, the management for T4 is total laryngectomy, which means that what this question is asking you is that what are the findings that will make this patient a T3 and will not make this patient a T4. Yes, yes, very good. For T4 lesions, yes, we go for total laryngectomy. Yes, total laryngectomy. So tell me, yes, what all this, when I see this patient, when I see the lesion, this appears to me a supraglottic lesion, and now this supraglottic, I can see that this is going to maybe the glottis also. So this is, by appearance, it is appearing like a T2 lesion, where it is not located to where it's not confined to one subside, it is going to the other subside also. So this is appearing to be T2. So just by appearance of the lesion, I can think that I can go for a TLM or a radiotherapy for this patient. I can prefer for a TLM also, or I can go for a radiotherapy for this patient, but I will have to go for a CT scan. I will have to go for ruling out that this is only the lesion that I have, because if this is gone to a T3 stage, then the management is going to change. The management is going to change to a concurrent chemoradiation, and if this is not a T3, if it is a T4, then again the management is going to change. So what are the things that will tell us that this is T3? Very good, the vocal cord fixation. Yes, vocal cord fixation. So I will look for vocal cord fixation. Very good. I will look for pre-epiglottic and paraglottic space involvement. So vocal cord fixation, pre-epiglottic, paraglottic, pre-epiglottic, paraglottic, and anything else makes it T3. Yes, if it goes to the pre-epiglottic. So if it goes anteriorly, if it goes laterally to the paraglottic, or if it goes posteriorly to post-cricoid, that also makes it a T3. If it goes to post-cricoid, that also makes it T3. And what are the things that I will look for to rule out that this is not a T4? So I will not go for a total laryngectomy for this patient. Yes, very good. Inner cortex of thyroid. Excellent. Inner cortex of thyroid. Inner cortex, limited to inner cortex only. Inner cortex of thyroid. What will tell me that this is not a T4? T4. So see, when we leave the question open, we have everything in our mind, everything we are open to think, so many possibilities open in our mind, that what are the things that will make us think that this is T3? What are the things that will make us think that this is not a T4 lesion? Yes, T4, very good, the cartilage. T4 means it is not limited to the larynx, it has gone outside the larynx. Outside the larynx, how do we remember? That is very simple to remember. When it goes anteriorly to the what is anteriorly to the thyroid, to the strap muscles, posteriorly to the to the esophagus, or it goes superiorly to the tongue muscles, inferiorly to the trachea. So when it involves the cartilages, so all that makes it T4. So if it has gone to, yes, T4, then we are not going to go. So that makes the so that is what all we are going to look for. So no matter whatever they put in the four choices, we will be able to answer. Yes, but one very important thing is left out, and yes, that is this. Which of the lymph node groups in this neck should be removed in the patient if the primary tumor is treated surgically? If the primary tumor is treated surgically, why is this given? If the primary tumor is treated surgically, because here in this patient, we were thinking of going for concurrent chemoradiation, okay, not surgery. So first of all, the first thing that I want to ask you is, will you go for the treatment of neck of this patient? Will you treat the neck of this patient? Will you treat the neck of this patient? What is given in the neck examination did not reveal any abnormal finding. Will you treat the neck of this patient? Yes, so let me wait for your answer. Are you going to do anything for the neck, whether a neck dissection or radiotherapy for the patient? Will you treat the neck of this patient? Ratandeep, Chaitanya, Suraj, Amruta, Pragati, Swati, Divya, will you treat the neck? Shek, Anjum, will you treat the neck? Yes or no? Ratandeep says yes. Chaitanya, no. Will you treat the neck of this patient? What do you think? Think. Yes? Yes. So, will you, Suraj, will you treat the neck? Supraglottic lesion? Supraglottic, yes. Eva says yes. Suraj Upinder says no. Soham says yes. Okay. So now, again, we are at a very, very important point. So listen to this carefully. Whenever there is, yes, Mohammed Saif also says yes. Yes. So whenever there is any tumor where there is any node in the neck, whether N1, N2, or N3, we always have to treat the neck. Whenever there is any lymph node in the neck, how do you treat the neck? If we are treating the primary tumor by surgery, suppose we are doing excision of the tumor, so for the neck also we will go for neck dissection. If the primary tumor we are treating by radiotherapy, if we are treating by radiotherapy the primary tumor, then the neck also has to be treated by radiotherapy. Is that clear? That was whenever there is a lymph node in the neck. Now, what to do if there is no lymph node in the neck for N0 neck? For N0 neck, what we saw when we saw the previous two patients, they did not have a lymph node in the neck, they were N0. But they were glottic carcinomas, where we know that the chances of lymphatic metastasis is negligible. So in those cases, we are not going to touch the neck, we are not going to treat the neck, either by neck dissection or by radiotherapy. But in cases where the chances of lymphatic metastasis are very high, for example, in pharynx includes all the nasopharynx, oropharynx, hypopharynx. In oral cavity, in pharynx, and in carcinomas of larynx, supraglottis. in supraglottic carcinomas, we know that they have very good lymphatic metastasis. And in these cases, even if the neck does not show any lymphatic clinically or on CT, there are very high chances that when we remove these neck nodes, it has been found that the lymphatic metastasis is there. So invariably, whether there is any neck node or no neck node, we treat the neck of these patients. If the primary tumor has been treated by radiotherapy, the neck of these patients is treated by radiotherapy. If the primary tumor is treated by a surgery, the neck of these patients is treated by surgery. So suppose in this patient we had treated the primary tumor by surgery. So what neck dissection would be done? The neck dissection in N0 neck, if there is any N1, N2, N3, which means if there is any node in the neck, the minimum neck dissection has to be either a modified radical neck dissection, or we can go for radical neck dissection. Whereas if there is an N0 neck, if there is no neck node, we are going for electively treating the neck. So that is elective neck dissection, and elective neck dissection does not comprise of removing so many things. We electively remove only selective group of lymph nodes. That is what is known as selective neck dissection. So here we are going to selectively remove which lymph nodes? Yes. Yes, Divya says 2, 3, 4, but here the markings is A, B, C, D, E, F, G. So what is the answer? Yes? Tell me. We have to go for neck dissection to remove 2, 3, 4. You are correct. It is 2, 3, 4 lymph nodes. So here, which are the 2, 3 and 4 lymph nodes? Which are the 2, 3 and 4 lymph nodes? Yes? A, B, C, D, E is what we have marked. A is the submental, B is the submandibular. Both these are 1. This is 1A, this is 1B. C is, yes, very good. This is 2A. This is also known as jugulodigastric lymph node, upper deep cervical. This is middle deep cervical. This is 3, also known as jugulo-omohyoid. And this is 4. And this is 5A and 5B. Okay, this is 5A and 5B. This is occipital 5A and this is supraclavicular 5B. So here we are going to remove the 2, 3 and 4, and this neck dissection is what is known as lateral neck dissection. If it was an oral cavity, carcinoma where there was a N0 neck, then in that case we would have removed which lymph nodes? In oral cavity, we would have removed 1, 2 and 3. In oral cavity, we would have removed 1, 2 and 3. That is known as supraomohyoid. This is in carcinoma of the larynx. That has been a repeated question in carcinoma of the larynx. We will go for lateral neck dissection. So here, if in this question, no matter whatever the choices are, if in this question the choices are, we will go for TLM, we will go for TLM followed by radiotherapy, concurrent chemoradiation, we will go for total angiectomy followed by radiotherapy, we will go for concurrent chemoradiation with neck dissection, or with concurrent chemoradiation with radiation to neck nodes. So no matter what the choices are, you know what the what you are treating. So just read the question, try to visualize the question, try to integrate the question in your mind, and try to come up to the answers, the possibilities of the answers that you have, the endless number of whatever comes to your mind, and that will make you revise not only that particular topic but complete the all the stages, whether you're going to go for neck dissection, which neck dissection. So that is going to make you revise everything possible. So that is what you are expected, and when you get into a habit of doing like this, the moment you read the question, half 90% of the answer is already in your mind, and the 10% you have to decide just by seeing the choices which one you have to mark. So that was just to open your mind, and that is what if any of these things that you told me that was T4, then the management would have gone to a total laryngectomy. And in T4 stages, or if there is a neck node N2 or N3, or we always give radiotherapy. So in T4 stage, always the management is total laryngectomy followed by radiotherapy. Total laryngectomy followed by radiotherapy. So that decreases the chances of recurrence. So I hope you got that. Chemotherapy, Ramesh is asking, chemotherapy is followed by radiotherapy or reverse? See, concurrent chemoradiation. What is concurrent chemoradiation? Concurrent chemoradiation is that we give a few courses of radiotherapy, like we give five radiotherapy sittings. In between we give one chemotherapy, then again 1 week of radiotherapy. In between we give one chemotherapy. That is concurrent. We are giving it together. That is concurrent. So adjuvant is after, neoadjuvant is before. Okay, so Swati asked me, what will our management here? Concurrent chemoradiation and neck dissection? See, we are giving concurrent chemoradiation to the tumor. So when we are giving radiation to the tumor, why expose the patient to surgery? For the neck also, we will give radiation. So that is what I want you to understand. Whenever the patient asks you that क्या करना है, मेरे ट्यूमर गले में अब कैंसर हो गया, क्या करना है, ऑपरेशन होगा, क्या करना है, गले में भी फैल गया है, गले में भी यहाँ पे स्वेलिंग सूजन दिखाई दे रही है, तो दोनों को हमें कैसे ट्रीट करना है? अगर हम लैरिंक्स को ट्रीट कर रहे हैं, अगर हम गले के ट्यूमर को ट्रीट कर रहे हैं विथ रेडिएशन, हम नेक के ट्यूमर को भी रेडिएशन से ट्रीट करेंगे. अगर हम ऑपरेट कर रहे हैं तो वी डू नॉट हैव टू, बाद में हमें रेडिएशन नहीं देना है, तो इट इज जस्ट वन सिटिंग. हम जब ऑपरेट कर रहे हैं नेक को, लैरिंग्स को हम ऑपरेट कर रहे हैं इन द सेम सिटिंग, द पेशेंट इज अंडर GA. Remove the neck nodes also by a neck dissection. You do not have to place the patient again under GA. You do not have to go separately. So whenever we are treating the tumor, and that goes for all surgeries, oral surgeries, for all, whenever we are treating the tumor, primary tumor, by surgery, we are going to treat the neck also by surgery. If we are going to treat the primary tumor by radiation, we are going to treat the neck also by radiation. हम दोनों चीज़ों, पेशेंट को दोनों चीज़ों से सब्जेक्ट नहीं करेंगे. अगर हम पेशेंट को सर्जरी कर रहे हैं तो हम सर्जरी करेंगे, अगर रेडिएशन कर रहे हैं तो हम रेडिएशन करेंगे फॉर ऑल द ट्यूमर, whether it is primary or it is neck. I hope you've got that. Yes, both will be same. Primary and neck will be same. Yes, the node will be the same. So exactly. Yes, I hope you got it. Yes, that was great. So yes, so I think that covers the how we are going to manage the larynx. So next time whenever you're going to do the MCQs, try to do it this way. Just forget that there are some choices given, just cover with your hand, otherwise the reflex is to go to the choices and just forget rest everything. And the purpose of ENT Thursdays is to keep you going, to keep you motivated, to because if you know that there is something coming up, and I will be there with you, it is more of a motivation for you to sit and study and to come up. So I hope this is helping you. For the next session, there are two options that we have. One is that some students are asking to start the pharynx, and some of them are starting to asking to do the foreign bodies of ENT. So we will put a poll, and accordingly we can do the foreign body next time, and then we can start with the pharynx next to that, or whatever we decide in the poll. So yes, that is what yes, I you know all the neck dissection. That was just a beautiful picture I saw, so I thought this is the sternocleidomastoid that you're seeing, and the neck nodes that we are seeing, that we say the two 3, 4, they lie below the sternocleidomastoid on the internal jugular vein. That is why they are named as jugulo-digastric. Here we have the digastric. It is named as jugulo-omohyoid. Here we have the omohyoid. Yes, it is. What are the three uh, non-lymphatic structures that we remove? One is the sternocleidomastoid, the other is the internal jugular vein, and the other is the spinal accessory. This nerve that is going here, the spinal accessory divides the 2 into 2A and 2B. 2B. So these are the three non-lymphatic structures that we remove in modified radical neck dissection. Yes. Okay. So uh, whatever you are tomorrow, whatever you dream to be tomorrow, begins with what you do today. You cannot just imagine to have a very healthy body at the end of the year and just keep sitting and eating junk and not doing any exercise. So whatever in any aspect of your life, whatever you are visualizing yourself to be after some time, you have to start the preparation now itself. So whatever you want to be tomorrow, start preparing today itself and have the courage to pursue your dreams. All your dreams can come true. Believe me, all your dreams can come true. But you have to have the courage to pursue them. You have to have the courage to get going, not to lose hope at any point of time. And that is not only for your academic dreams, that is for any dreams that you have. I know all of you are so multifaceted, you are so versatile, all of you. So for any dreams, all of your dreams, just live your life and pursue your dreams. I'm sure you'll be able to achieve each one of them. So all the best. God bless you. Love you all. We'll put the poll and we can decide what we want to do next. Some people are saying we want to start the year also, but we'll go in a systematic pattern.